Hello and welcome to this recording on the ethics of self-disclosure. My name is Diane Bigler, and I'm happy to bring you this ethics training. There are corresponding handouts that go along with this presentation, and I will be pulling those handouts up on the screen as I talk about them. Also, please do feel free, even though there are some things in this training that are designed for a live audience, please also feel free to engage in some critical thinking skills when there's a question perhaps that I pose, and may encourage you to think about things even though there are not other people to discuss them with, either in person or in the chat box. We know that self disclosure in our field is an area of ethics that we are consistently needing to look at and be aware of and understand the dynamics. So, today we're going to look at some different areas of the ethics of self disclosure. We're going to identify different types of self disclosure and categories. We're going to look at some of the ethical considerations for and against, pros and cons, and looking at different situations in which self disclosure may or may not be appropriate, ethical, or suitable for the client. And then finally, we're going to look at employing specific clinical skills and ethical skills to manage difficult self disclosure situations. As we get started, speaking of difficult self disclosure situations, let's start with a vignette. Joe is a clinical social worker at a mental health center and counsels people struggling with major mental health and substance abuse issues. One of Joe's clients, Craig, was referred to Joe by an employer concerned about Craig's job performance. The psychiatrist at Joe's mental health center diagnosed Craig with bipolar disorder and cocaine addiction. Joe worked with Craig on ways to manage and cope with his co occurring disorders. Toward the end of a counseling session, Craig asked Joe whether he was in recovery. "You seem to know so much about this process," Craig said. "Have you had personal experience with addiction? Are you in recovery too?" In fact, Joe was a recovering alcoholic, but he was unsure about how to respond to Craig's direct question. So, this is a scenario that some of you may have found yourself in different capacities, whether you work in addiction recovery or you work in another area of the field. Having lived experience along with the population that you're serving sometimes can bring up the issue of, should I self disclose, especially when I'm asked by a client if I have similar lived experience. And in this case, Joe, the social worker, does, but he is unsure about how to respond to Craig's question. Should he disclose? Should he not? What do you think? Looking at this scenario, imagining yourself in Joe's situation, do you think that he should share with Craig, his client, that he is in recovery? What do you see being the pros of doing that? What do you see of being the cons or the things that we really need to consider ethically, clinically, relationally? What are the pros and cons of him not disclosing? We need to think about that as well. So, the really important thing here for Joe to do is to just pause before he responds, really be able to think about and be mindful and use that pause before he actually responds. Sometimes people have also said maybe asking Craig, how might that be valuable, knowing what my status is, either being in recovery or not being in recovery, and seeing what Craig says and what dialogue kind of comes from there. So I think that's a really good idea to think about therapeutically to do. Let's look at some reflection questions. This is going to be in the first page of your handout. And I am pulling those up on the screen here. This is a reflection exercise just for you to do individually. Feel free to get comfortable and take a few deep breaths. Think about a time when you disclosed something personal to your client and it went well. When did you decide to self disclose? What did you disclose? Was it an individual, couple, or family? Did demographics play a role in your decision, whether the client was male, female, a child, an adolescent, an adult, their ethnic background, religious background? What thoughts or feelings did you have before, during, and after the self disclosure? Does this positive experience inform your current decision making process? Now, think about a time when you disclosed something personal to your clients and it did not go well. Same questions. When did you decide to self disclose? What did you disclose? Was it an individual, couple, or family? What about demographics in any of these areas? What were your thoughts, feelings before, during, and after the self disclosure? And did this negative experience inform your current decision making process around self disclosure? So, really thinking about recalling a time where you had a good experience disclosing something to a client and went well. It was therapeutically beneficial to your client. There was some level of awareness of that. It was received well, perhaps. But then some of us may have had experiences where it has not gone well. And so thinking about the other side of that as well. Okay, let's go back to the PowerPoint and let's define self disclosure. A couple of definitions here. Self disclosure is the revelation of personal rather than professional information about the therapist to the client. Anything that is revealed about the therapist verbally, non verbally, on purpose, by accident, wittingly or unwittingly, inclusive of information discovered about them from another source. The sharing of personal information by the therapist with the client, excluding details regarded to the treatment, the therapist credentials, office policies, and emergency contact details. And then this is interesting. The answer says that in reality, therapists generally do disclose personal information about themselves and their beliefs, and that it happens more often than many would assume. So you may not think that you are disclosing a lot to your clients, but maybe you are in some ways without even realizing it. I'd like you to identify here on a scale of 0 to 10, currently, right now, what is your level of comfort with self disclosure in general? Would you say you lean more on the conservative, rarely okay end? 0 to 3, are you somewhere in the middle? Or do you lean more into it's often okay between, let's say, 8 to 10? So go ahead and select a number and write that number down somewhere in front of you. Some more interesting perspective and data on self disclosure in our field. Most therapists report disclosing at some point in therapy. Henretti and Levitt report that 90% of therapists report disclosing occasionally, and sharing that 19 out of 10 practicing therapists acknowledge disclosing something to their clients. Also, Audette identified two distinct categories of therapist self disclosure. And let's look at those. We have both immediate and non immediate self disclosure. So, taking a look at immediate self disclosure, as you see on the left hand side on top, this is the interpersonal self disclosure. This is referring to the revelation of the therapist's feelings about the client, the therapeutic relationship, or an in session event. So, this could be sharing with a client that you're very moved by their story or you feel very sad inside because they had to go through that, whatever that is. Another example you see here would be a therapist telling their client that when she is regularly late to sessions, he is left wondering if she values her time in therapy. So I was a DBT therapist, and one of the things that was important in our skill building as DBT therapist was the use of appropriate therapeutic immediate self-disclosure. So it's really important in DBT to address any process or treatment issues in therapy with the client. And the therapist needs to be very assertive in doing that, but also needs to do it in a way that is very respectful and therapeutic. And certainly, there are times in which the DBT therapist does disclose some immediate self disclosure about their feelings, about their own perspectives regarding something in the session, the therapeutic relationship, etc. The other example that we have is non immediate self disclosure, and non immediate self disclosure is considered intrapersonal. This is information about the therapist directly. So, their personal life, their beliefs. And this is where it really does kind of start to shift the focus away from the client, is when the therapist really starts to reveal about themselves. We see that there can be this shift if there's not a mindful awareness and management of that disclosure by the therapist. Typically, we find in these situations that a lot of therapists are not even aware of the type of self disclosure that they are engaging in. And so they may not be aware that it is therapeutic to share with clients your feelings about a session or a moment in the session, any impressions that you think are noteworthy that come from within you to share about the client's progress or lack of progress. So there's a lot of opportunity to provide appropriate, immediate self disclosures. As you see here, another example of a non-immediate self-disclosure is a therapist who shares that they also have experienced a similar traumatic event. Doesn't mean that this is always appropriate, but it doesn't mean it's always inappropriate, right? And so when done skillfully and when it is appropriate for the client, what we find is that a good delivery and an appropriate ethical delivery of self-disclosure promotes client and therapist rapport, conveys the fallibility of the therapist, and makes the client therapist relationship more equal, egalitarian. And so looking at the sometime benefits, and I'll talk later about the frequency of disclosures can be really important as well as we are making decisions about whether or not how often to disclose, how many times with the same client, those kinds of questions. So, researchers took on the task of obtaining video and audio recordings of Carl Rogers' sessions. You are probably familiar that Carl Rogers is the founder of humanistic and person centered approaches in psychotherapy. He's considered one of the most top influential therapists of the 20th century. And Carl Rogers had a really amazing career, not just as a clinician, but also as an author, as a speaker, and as somebody that really influenced a lot of people in the field and still influences people in the field with his person centered approach. So, researchers were interested in looking at and examining Carl Rogers' frequency and types of self disclosures in therapy. So back in the day, it was not uncommon that therapists would either record or would transcribe their sessions and have their sessions transcribed. It was just something that was done more often 60 years ago or so. And so the researchers were able to get a hold of 172 of Roger's sessions and were able to begin to track the types and the numbers of self-disclosure. So we're going to look at that in just a second. We're also going to look at the different types of self-disclosures that are common in our field. What I'd like to do first is look at a self-disclosure survey that is in your handout packet. So let's take a look at that. These are some additional self-disclosure questions that may be interesting for you to take a look at. How often, if ever, do you disclose with clients? Would you say often, periodically, rarely, or never? Do you use self-disclosure more often in the beginning of treatment, during the middle, or near the end of treatment? As first compared to when you began working in the mental health field, how often do you self-disclose? Would you say compared to when you first started, extremely less often, somewhat less often, somewhat more often, or extremely more often? Do you self-disclose with clients who are the same sex as you? Never, rarely, sometimes, or always? Do you self-disclose with clients who are the opposite sex as you? Never, rarely, sometimes, always. When you engage in self-disclosure, how often do those self-disclosures consist of factual information about yourself, feelings or events in your own life, feelings about or towards the client? In your training program, were there classes or lectures about the use of self-disclosure? Have you ever been in therapy? Did your therapist self-disclose to you? If so, how did it affect your working relationship? If any of you that are listening to this training are in that arena or on the continuum of being non self-disclosing therapists, so you'd be on that 0 to maybe 2 continuum that we looked at earlier, think for a minute about why you do not self-disclose in your work with your clients. Do you think there are better techniques? Do you think it's harmful to the client? Did you have a bad experience either providing, sharing self-disclosure as a clinician or being on the receiving end or any other reasons? These questions were actually part of a research study that was done on self-disclosure. Later, I'm going to share with you some of the quotes from clients that were part of another research study. There's been not that many research studies done on self-disclosure in therapy. We have just a handful, but I'll share with you later some of the client viewpoints about self-disclosure, and I think you'll find those very interesting. Going back to looking at different types of self-disclosure, let's look at all of these different types of self-disclosure here. We have 7 different types and then some examples. First one is disclosure of facts. I have a doctorate in counseling psychology and work primarily with students. Disclosure of feeling. When I've been in situations similar to yours, I felt scared because I didn't know how many things would turn out for me. Disclosure of insight. When I was having a similar conflict with my colleague, I realized that I shut down because I was afraid that he would reject me like my father did. That's a pretty significant one from a therapist to a client. Disclosure of strategy. When I faced circumstances like yours, it helped me to gather as much information as I could so that I would be able to be prepared for what might happen. Disclosure of reassurance and support. I understand your anxiety because I also have a difficult time when I give a talk. Disclosure of challenge. I don't know if you are aware that I too am divorced and had to think long and hard about the contributions to the failure of my marriage. And then disclosure of immediacy. As you describe the cold relationships in your family now, I am aware that I'm feeling very distant and closed off from you. I wonder if that is similar to how you felt with your family. So some of these seem like they would be, pretty appropriate disclosures, but some of them you may be wondering, would that really be an appropriate disclosure? Let's look, for example, the one where the counselor discloses that under disclosure of challenge, that they too are divorced. Can you think of any settings, situations, practice settings in which it would be appropriate to share with a client that you are divorced? And how to think about your contributions to the marriage ending. We would imagine that within couples marital counseling, we could see that this would be an appropriate disclosure given obviously the client or clients you're working with to share with a couple in giving them some perspective and perhaps them seeing you as a role model and being able to give them this piece of information. They don't need to know the circumstances of the divorce, but the point here is that you're able to share some of your lived experience and you're also sharing the skill of being able to be self-reflective. So rather than just saying to the client, you should really think about your contribution to this, the failure or the challenges in your marriage, we are giving a little bit of information about ourself and our own process in that. So there's the therapeutic benefit. The disclosure of immediacy, the last one. We would typically see this maybe in psychoanalysis where the therapist is going to be really cued into how they are feeling and is going to be sharing that with the client. And this is that disclosure of immediacy that we looked at earlier. This is that immediate self disclosure where the clinician is wanting to share a thought or feeling, something that's resonating with the clinician. And that's what this example is here. I want to go up to the disclosure of insight because, saying to a client, I was afraid that he would reject me like my father did. This is another personal piece of information about the therapist that some of you may be thinking, oh gosh, I don't know if I would ever say that to a client. But think about how that could be beneficial, especially if as soon as you say this, you turn it back over and focus on the client. You don't stay in your world or continue with your story or with your dad or what he did. That this is enough to perhaps give some perspective and humanize you, that you are not just a therapist that doesn't have a past or feelings or experiences or challenges, but there are some things in our own life that perhaps we can share with our clients to give them some really good perspectives. Okay, so this was the results of the study done on Carl Rogers and his self-disclosure. He did not disclose much to his clients. In fact, they only found 21 disclosures out of 8,668 different pages and text. So looking at all these different text, they counted each one of those lines of text in that number of 8668, 0.24%. Here are the types of disclosures. Most often, Rogers engaged in disclosures of immediacy. So, the last one, which makes sense when we think about person centered approaches, in that the therapist is going to very often be self reflecting both internally but then also externally with the client. So it makes sense that even though Rogers did not have a lot of self disclosures in terms of volume, the types of self disclosure we see immediacy and then facts. Seven, reassurance and support, three, feeling, and then two, challenges. And then here are examples. Immediacy. I feel very appreciative that you've been willing to share this with me. Fact. I love this one that he shared. I seem to have a terrible cold today, right? Just being very honest. Reassurance and support. I think you are making progress and understand how hard it is to keep going. Feelings. I'm also skeptical that you will find the answer that way. And challenge. I think that you and I want something very different for you. Can you imagine having Carl Rogers as your therapist and having him say that last one to you? Right? So I thought that was really interesting, just relevant to our discussion on self disclosure. Let's now look at going back here to the presentation. A perspective from Frederick Reamer. Frederick Reamer is one of my favorite social work ethicists. He has been in the field for probably 40 years or so, and he has been heavily involved internationally and with NASW in the Code of Ethics revision about 12 years ago. Frederick Reamer has written a lot of articles and is considered a scholar and a mentor in terms of ethics. And this is his perspective on self disclosure. Clinician self-disclosure can blur boundaries, damage a client's trust, shift the focus of the relationship away from the client, and undermine therapy. However, handled skillfully, judicious self-disclosure can enhance a client's sense of reciprocity in the clinical relationship, strengthen the therapeutic alliance, facilitate client trust, contribute to a more collaborative worker-client relationship, provide the client with a powerful role model, demonstrate the universality of human frailty, and normalize the client's challenges. So, what Reamer is really saying here is there's this duality in self disclosure that we need to be aware of as clinicians. There can definitely be some ways in which it can impact our clients, ourselves in a not very positive way. And then there can also be ways where it can be beneficial, as you see all the different reasons that he listed here. I'd like to introduce you to a great model that will help us better understand how we conceptualize self disclosure from an ethical and clinical perspective. So, in this model, you see there's quite a bit going on here. But you see at the bottom, there are these two boxes, the unique therapist and the unique client. Let's start with the unique client first. So every client comes to us with their own individual awareness level, wellness, personality, self-disclosure. Some clients are really open and other clients are not. Vulnerability, embodiment and anxiousness, worldview, and belief system. On the left, you see the unique therapist as well. And we also have our own personality, self disclosure, opinions, practices of self disclosure. We have our own vulnerabilities. We have our own anxious thoughts, feelings, experiences as a professional and a human being. We have our own worldview and we have our own belief systems. The other two areas, awareness and wellness. Let's shift up to the top and you see these two areas of therapist awareness and therapist wellness. You also see the two interwoven cyclical arrows, which represent the fact that one of the key aspects of really ethical self disclosure is a therapist level and skill in wellness and awareness, being aware of who you are, your needs, your vulnerabilities, your urges to share information with a client when it should not be shared, and also your wellness. We know that therapists that have more burnout, who experience more compassion fatigue, they are more likely to over disclose and cross that boundary in a way that should not be crossed. So, therapist awareness and wellness is hugely important in the context of self disclosure. With that awareness and wellness, we want to make a connection. We want to make a connection with our client. We want to create, as you see in the middle, a sense of mutuality, right? This level of mutual relationship, trust, safety. You also see relationality, intersubjectivity, and attachment. How do we attach to clients without opening ourselves up and sharing too much of who we are? There's a really good balance there, and it can be difficult sometimes to find that, especially with clients that we're finding it hard to form that attachment with. And so we may become desperate, and that may lead to us over disclosing in an attempt to form that therapeutic attachment with the client. So that's something really to be aware of. The clients that are not warm and receptive from the very beginning, make sure that you are aware of any tendencies to use self disclosure as a too frequent intervention. I'd like to show you a short video here called Managing Disclosures in Therapeutic Relationships. It is by a clinician, Dr. Karen Hellam, and she's going to be talking to you and giving you some really great concepts around self disclosure. And when possible, I do turn on the closed caption for those that find it helpful.
Hi there, my name is Dr. Karen Hallam and I am a Senior Research Fellow at YSAS in Melbourne and also a clinical psychologist. The reason I'm talking to you today is for a really important element of the therapeutic alliance. Often we talk about the therapeutic alliance as just the relationship between the therapist and the person they're working with. In reality, it's actually a really nuanced and unique relationship that sets a person up for their recovery for many years to come. An element that I'm often asked about and people struggle the most with is how to set their boundaries with people. When we talk about boundaries, we mean a whole range of different things, but often the thing that's most challenging is personal boundaries. I have a really simple way of trying to understand that concept of personal boundaries, and it comes from the work of Irvin Yalom, who's a great existential and humanistic therapist. When I think about it, I think of three circles: the largest circle, a moderate-sized circle, and a circle right in the middle that's very small. The largest circle is what we call the here and now. The here and now with a therapeutic relationship is the good stuff. It's the talking in the room about somebody's experience of being helped. It's about talking about the issues that have come up. It's about talking about their experience of how you are as a therapist as well. It's also you giving them direct feedback and letting them know what is and isn't appropriate in the settings that you're in. Finally, here and now gives you a chance to talk about their experimentation with behaviour. What if they tried something different? You come back to the session, you talk about how it went. Here and now is always energetic, it's always exciting, and it's a great opportunity to actually see and feel how this person interacts with others. There's that middle level of disclosure as well, and this is just what we call the fellow traveller self-disclosure. This notion of the fellow traveller is about 50 or 60 years old, but basically says, I'm a human, you're a human, we're in this room together. We're talking about hard stuff, but we're still just people. So when somebody asks me if I have a dog, I say yes. I tell them what my dog's name is, I tell them what breed. I ask them if they have a dog. They might say yes or no. They say no, I might ask them if they want a dog. What would be good about having a dog? Do they like petting a dog? Does it comfort them? Do they learn anything from their dog? What type of dog would they like? That might tell me about their personality. Likewise, if somebody says, have you been to the latest Avengers movie? I'm going to answer them. What's the cost of not answering? Very little. They don't learn anything much about me. They don't learn anything inappropriate, but they get an opportunity to just see how human you are. The last level is very, very small, and this I call here be monsters. This is personal disclosure. This is talking about your own life. There's a big temptation to talk about your own life when there's some similarities between your experiences and somebody else's experience as well. My warning about this type of disclosure is not that you could never do it. Sometimes it might be appropriate, but I'm going to give you some reasons not to do it and to find a different way in the here and now or in the fellow traveller ways. Some of the reasons not to self-disclose are because it starts to blur the boundaries between what is a therapeutic relationship and what is a personal relationship. When they get to know you personally, often people protect you, they take care of you, when perhaps you don't need to be taken care of. They might stop telling you things that would disappoint you. They might stop telling you things that would upset you. They might stop sharing if they are not doing so well, which is a real difficulty because we want people to be honest. Likewise, they can get really upset with themselves if they don't cope with the problem as well as you coped with the problem. They compare themselves to you. This also sets people back. And finally, if they feel that you're judging them or that they're not performing for you well enough, they're very likely to disengage from therapy or become really angry in therapy. There's lots of reasons not to self-disclose and only a very few to do it. I would always encourage you, if you're about to self-disclose something, to really ask yourself, am I doing this for me or am I doing this for them? If you answer the former, maybe, I again encourage you to think a bit more about it because there's so much more that could be done with a fellow traveller statement or a here and now statement. So they're my 3 ways of thinking about self-disclosure. None of them are hard and fast rules, but they're the ways that I go through my therapeutic experience and find that I do my very best work with young people.
I am here to tell you.
Okay, so that was Dr. Karen Helm, and I love showing that video in this training because I think that she gives some really great concepts and ideas and perspectives to think about this here and now, here be monsters, and fellow traveler, those concepts. And I think that the way that she approaches self-disclosure from this really healthy, balanced, that if a client asks me if I have a dog, I'll say, yeah, I have a dog and his name is Skip, right? But then also looking at some of those here be monster categories, which are areas that we should not lean into in terms of giving self-disclosure to clients. So some really good concepts there to begin to frame our discussion. Let's look at some key points about self-disclosure. Usually when we think of self-disclosure, we think of the therapist as revealing something personal about themselves, something, that is private and personal and perhaps intimate. But actually what we find is that there's so many other ways that we often see self-disclosure is happening. These can be verbal, which is the way in which we speak, what we say, and they can also be nonverbal. So what are some ways that you think of can be self-disclosure non-verbally? What comes to mind? We're going to look at a list here in a minute, but just reflect for a second on what do you think are some non-verbal examples of self-disclosure? Let's look at a list and see if you thought of any of these. The therapist ethnicity based on surname, or perhaps based on the way that the therapist looks. Sometimes that can be revealing in terms of ethnicity, race, but somebody's name can really indicate perhaps ethnicity. Speech, so the volume, the accent. So if you are a therapist practicing in New York City, but you're originally from Georgia, born and raised in the South, and you've recently moved to New York City, you're probably going to have a Southern accent that is going to be different and be kind of atypical and catch more attention in terms of people being able to quickly recognize that you have a Southern accent and may ask you, "Oh, are you from the South?" So sometimes our speech can disclose something. The way that we dress as clinicians, wedding rings, other rings, the types of clothes we wear, if you wear a shirt that has a saying on it, or a brand, or a slogan, religious symbols worn or religious holidays observed, office decor, family photographs, pictures on the wall, decorations, the colors that you select, diplomas, certificates, the school you went to, the year you graduated from, what your degree's in, etc. Information on your website. Certainly, and some therapists are really open. For example, if a therapist is LGBTQ, they may openly disclose that on their Psychology Today profile or their website. And that is something that they're comfortable doing because they want to feel people within that community feel comfortable coming to see them. Information provided by the therapist employer. So this could be a hospital, an organization, and any sort of rosters or directories. There are actually some, especially government organizations, cities, counties, states. If somebody's an employee of a city, county, or state, sometimes those salaries are searchable and are public information. So your client may be able to find out what your salary is. Nonverbal reactions, so facial expressions you have, and just any other kind of, posture, movement, the way in which you're positioning yourself, laughter or refraining from laughter, verbalized reactions such as, oh, wow, or geez, or ooh, or silences. And then absences from session, illness, pregnancy. Some of you may have been in a situation where you need to be absent for more than a day or so, and you have to figure out what am I going to tell my clients because I'm going to have to be out for a few weeks, and what am I going to tell them? So I know during COVID, this was a thing. As therapists were getting sick and getting COVID and couldn't work for weeks, that they had to figure out how they were going to communicate with their clients. They couldn't just say, "I'm not going to be in for 3 weeks." You have to give some context to that reason, even if it's just saying, I have a health issue, and they may be like, "Is it COVID?" And then you can decide whether or not to tell them or not. But this is some of those situations that can be brought up and get us to really think about um, types of different disclosure. A lot of the ones we just went through are these inevitable self-disclosures, right? Things that we may not think of that are just part of our life, who we are. But as we looked at earlier, one of our earlier kind of points on self-disclosure from Danzer said that therapists disclose more often than they realize. So you may not be verbally disclosing a lot to your clients, but that doesn't mean that you're not disclosing in other ways. Just right now, sitting here watching this training, the artwork that I have behind me on my wall is a disclosure about me. You see a dog, which probably tells you I have dogs, which I do, 4 dachshunds, just like the photo. And you see there's a photo of, or a painting there of fish. I love the ocean. And then there's also a painting there of the military because I come from a military family. So uh, our own way in which we construct our world, whether it's the way we dress, the photos we have hanging on our wall, tell a story and often send messages. And a lot of our clients are curious about that. Some clients may not even care. They don't care what's on your wall. They don't really care about your family photos or where you went to school, looking at your degree. But there are clients that do become very interested and curious about that. Sometimes just in a normal, typical kind of curious way, but other times in a more insistent, curious way. And we'll talk about how to deal with that at the very end of the training. Okay, so even though this is not a live training, go ahead and test your knowledge in matching up each of these different types of self-disclosure with the different types that you see in the word bank: deliberate, unavoidable, accidental, inappropriate, and client initiated. So I'll read each one of these if you want to write down what you think that type of self-disclosure is, and then we'll come back and we'll look at all five of them. Number one, meeting a client while out with your family at a community event. And I'm just pausing in between each one to give you time to select from the word bank the type of self disclosure. Do you think it's deliberate, unavoidable, accidental, inappropriate, or client initiated? Number two, gender, age, a distinctive physical characteristic, such as a visible tattoo or pregnancy. Number three, a client seeking out clinician, family, and friend connections, volunteer activity, religious affiliation, political affiliation, community involvement, legal court documents, personal photos, video postings. So the client is seeking out any of that information about their therapist. Number four, verbal sharing by clinician of personal information or a specific action, such as placing a family photo in your office. And five, clinician discusses their own personal problems and hardships with their clients with no clinical rationale or purpose. Okay, let's go through and we're actually going to, rather than starting with the number one, we're going to find out, go in order according to our word bank. So we're going to find out first which one is deliberate self-disclosure. If you guessed number four, sharing by the clinician of personal information, a family photo in your office, that is deliberate self-disclosure. Which one did you select for unavoidable self-disclosure? If you selected B, that is correct. Gender, age, a distinctive physical characteristic, visible tattoo or pregnancy, that would be unavoidable. And then accidental, which one do you think is accidental? That one is C. C is, I'm sorry, number one, meeting a client while out with your family at a community event. And then number five is D. Clinician discusses their own personal problems and hardships with their clients with no clinical rationale or purpose. And so that means, which I think this one's pretty obvious, is that number three would be client initiated, which is not something we can control. We can, to some degree, especially in social media, we can control that. But the age of the internet and people being able to find out lots of things about other people, unless you pay a company to professionally scrub your web presence, we all have a web fingerprint, so to speak. And so if clients get really curious, they can just go on a crazy search and find out different information. And sometimes they come into back to see us and say, I looked you up and found out blank about you. And that can be a little bit unnerving when you realize a client has intentionally sought out information about you and then they come back and they share that with you. And how are you going to respond to that? That's really key in terms of how you're going to address that, interpersonally, therapeutically, or are you just going to say, oh, really? That's nice, right? And maybe you don't need to address it. So that's going to depend on the situation, the client, their presenting issues, etc., in terms of how you proceed. So I wanted to highlight what the different codes of ethics say. We have NASW, which is conflicts of interest can emerge when social workers disclose personal information to clients, whether for purposes of intimacy and emotional connectedness, personal benefit, altruism, or as a result of unexpected or unanticipated circumstances. So those of you that are social workers, NASW makes it pretty clear under 1.06 that inappropriate or excessive self-disclosure can create a conflict of interest and can lead to a boundary violation. A boundary violation is when a professional engages in inappropriate boundaries with a client, and those behaviors are exploitative of a client, they are coercive, they damage or harm the client. A boundary crossing is when a clinician engages in an ethical crossing of a boundary, but it is ethically within guidelines. For example, a client is doing in-home therapy and they're working with a family that is not from the United States, and the family offers a meal to the worker or a snack from their country. And the worker decides for the therapeutic relationship and to be culturally adaptable and embracing the culture of this particular family to accept that snack. And so that would be an example of that is not something that's going to get a social worker in front of the licensing board. Now, if a social worker is asking a family to prepare them a meal when they're going to visit them, that would be an example of a boundary violation. So you see the difference there. So really important part of what I'm going to kind of mention today is that self-disclosure is not inherently wrong or bad. Uh, you may have been taught that in school that you should never ever self-disclose to your clients. Self-disclosure, none of the codes of ethics say that we should never ever self-disclose. As you see here, what they say is that the focus should always be on the best interest of the client. As you see with the ACA code of ethics in the middle, self-disclosure should only be engaged in when there is an inherent benefit to the client. So we need to determine that before we are disclosing. So in the initial opening vignette of Joe and Craig, the counselor, Joe, the counselor, the social worker, really needs to think about if I share with Craig that I too am in recovery, will that be of benefit to him? Will that derail his counseling? Will it shift the focus to me? Or could it enhance Craig's motivation and his desire to remain sober and have a sober life and maybe become a counselor? Who knows? So that is our responsibility to weigh all of these things in terms of, is this in the best interest of the client? If you are a marriage and family therapist, MFTs do not use their professional relationships with clients to further their own interest. Also, if you are a psychologist, the APA also has some guidelines. I don't have them in the slide here, but they do have guidelines that are similar to NASW, ACA, and AAMFT. And so those guidelines basically say the same thing, that psychologists are responsible for using their judgment to determine engaging in behaviors that are only in the best interest of their clients or patients. What do clients say about self-disclosure? Really interesting when we look at what clients say. So I have several different perspectives from actual clients that were interviewed about their thoughts and feelings about self-disclosure. So let's take a look at these. I have no idea why the therapist disclosed the thing about her pregnancy. It came out of the blue. I think she was excited, so she decided to tell someone. I don't really want to know about her. I can't imagine why she would tell me personal stuff. But if it concerns our therapeutic relationship, then it's okay. She sometimes makes examples about her training, but she makes it a generic sort of thing. She doesn't brag about it. It showed when the therapist disclosed more about her family that she acknowledged that she was human with a life, not a robot or a god. I mean, she can't hide some things from me because she practices from home. She doesn't disclosure very seldom, and when she does it, it means something because she is bringing herself into the room, and I really like it. I was hurt because my hopes were dashed after the disclosure that the therapist was also having relational problems. Because at first, when I went there, I thought that the problem was transient and solvable, but now it's not going to be resolved, and then it's a huge problem. That increased my pain and worries because the problem now seemed bigger and serious. I think I sort of get frustrated by her, by the professional nature and sort of detached, cold manner. When she refused to tell me, I thought, Lord, why can't you tell me because everybody has a birthday? She was being annoying, petty, silly, and unnatural. I was able to open up after the therapist disclosed that she had also struggled with her studies at some point in her academic life. Yeah, I got to understand that this person is not here to judge me, but she is here to listen to me and help me deal with the things which were emotionally challenging. I actually felt that there are people who are going through more than what I am going through. I felt comforted and hopeful. So I think that gives us some very interesting and diverse perspectives. You hear from some of these clients that they really appreciated their therapist self-disclosure. Other clients were kind of puzzled, like the person up in the left-hand corner, upper left-hand corner in the purple box, the pregnancy disclosure. And maybe this client, I kind of am getting that, was feeling off guard a little bit when the therapist disclosed that. Didn't really get the sense of why the therapist was disclosing that to the client, but thought, I guess she's excited and wanted to tell someone. And then you also see, for example, on the right hand side in the purple box, the client that asked about birthday. So I'm curious, think for a minute, and if this was a live audience, I would have you put it in the chat box. Would you be comfortable if a client asked you your birthday? Not the year you were born, but the month and the day. So they ask you and you say, I was born March 6th. Are you comfortable sharing that if a client were to ask you why or why not? There's no right or wrong answer. This is more about just assessing your level of comfort. Let me ask you this. Does your comfort level change if the person asking you is a child versus an adult? Does it matter? The age of the client, the gender. So think about that. A question as simple as when is your birthday? What month were you born? What year or what day? Is that something that you are comfortable with? There's a great acronym that Dr. Richard Schwartz created around self-disclosure. WAIT. Y am I telling? Why am I telling? So this is a great way to remember That main point that we looked at in the code of ethics and we've been beginning to emphasize is that self-disclosure should be client-centered, it should be client-focused, and it should be in the best interest of the client and not take away from the client. The other things that we need to look at when we're looking at the appropriateness of self-disclosure is content, intensity, and timing. Content, what are you sharing with the client? What is the content of your disclosure? Is it a feeling? Is it a fact? Is it a disclosure of immediacy? What is the content? We also need to look at intensity. What is the level of intensity of your communication of this self-disclosure? If the intensity is feeling high to you, then you should not make that disclosure. If you're feeling like you're very overwhelmed thinking about making this disclosure, or you're very passionate about what you want to share, then you probably should rethink it because too high intensity or even too low intensity can be problematic. And then timing. We have to assess, is this the right moment with this client to share this? I know I've been in the situation where I've had it on the tip of my tongue, and then I realize, oh, nope, it's actually not a good time. Hold back, don't proceed. And so we really need to be able to sometimes put on the brakes and adjust our timing to be flexible. Just because it enters our mind doesn't mean it has to come out of our mouth. So I would like to show you two video clips. They're very short. They're just about a minute and a half each. And it's the same client, the same provider. I'm going to show them back to back. So I'll play one video and then I'll just immediately play the next video so that you can look at them in comparison. And what I'd like you to do is take a few notes on what you observe in both of these videos in regards to the provider, the client, provider's just level delivery disclosure, the client's response, anything you notice that you think is noteworthy in both of these videos.
to
This is video number 1.
Hi, Abby. Nice to meet you. I'm May.
Hi, May.
So I got the referral from Dr. Washington that says that you're newly diagnosed with cervical cancer.
I was. I don't even know how to take all of this in. I don't know what to tell my husband. I haven't shared it with my family. I don't know.
So when I shared it with my husband, he freaked out as well. But I've been living with it for 5 years, and so I've actually have a really great provider, and I also go to this woman health center that specializes in homeopathic care. So I can give you the referral for that. So what I found that works best for me with dealing with this disease is to make sure that I do a little bit more research on the oncologist that I'm going to be working with, particularly to make sure that he or she is like they do a lot of they do a lot of treatments around cervical cancer. And I also find that when so what happens after the chemotherapy was I actually found that a support group is really helpful as well. And I can definitely refer you to the support group that I've gone to. And they've really also have a lot of other resources that they can share with you as well.
Okay, that's video 1, and now I'm going to play video 2.
Hi, Abby. Nice to meet you. I'm May.
Hi, May. Nice to meet you.
So I got a referral from Dr. Washington that said that you're newly diagnosed with cervical cancer.
I was. I was recently diagnosed. It's all new to me. I don't even know how to handle it.
Tell me a little bit more about, you seem very nervous and anxious, so tell me a little bit more about how you're feeling.
Well, you know, I feel scared. I don't know how to tell my family. I don't know who I should tell. I don't even know how to tell my husband. I just feel really alone.
Those are natural reaction. I've had cervical cancer before, and part of our work here together will be to figure out possible treatments for you, as well as additional resources that you might need as you go through those treatments. And also, if you want, we can also work together in figuring out should you want to tell people, who to tell, and when to tell them. So what's great about this clinic is we're provided the opportunity to do that together.
Okay, thank you.
Okay. Short clips, but let's kind of reflect on what you observed in those video clips. In video clip number one, you see the provider with the patient, and you see that there is this immediate disclosure by the provider that she is a cervical cancer survivor. And then it launches into, she says, when I told my husband, he freaked out, and then just kind of goes on from there. And it pans over to the patient, and you can see on her face that she is probably kind of looks like she's feeling overwhelmed by the fact that this provider is just going on about her own experience when the patient is there to really get some help and support for herself. So, in the first video, we really learned nothing from the patient because the provider talked the entire time. So, that would definitely be a thumbs down, right? We would not this provider needs a lot of coaching and needs a lot of skill development in being able to appropriately utilize self-disclosure. What did you think of video number two? Video number two, did you think that video number two was any better? Was it a little bit better? It was a little bit better, right? We still had the disclosure of I had cervical cancer. One of the things that we need to realize is that, and I'll talk about this here in a few slides, is in some settings, it is more natural and more culturally acceptable to disclose something. And in cancer settings, it's not uncommon that providers will disclose something to their patient that they also perhaps are a cancer survivor. And that can lead a patient to feel a sense of hope, a sense of encouragement, a sense of that this provider gets what I'm going through. I remember just to self-disclose, ironically, but I remember 5 years ago I was diagnosed suddenly with leukemia, very aggressive leukemia. And during my journey through chemotherapy and getting a bone marrow transplant, one of my nurse practitioners, who was one of my favorite providers that I worked with when I was in the hospital, she actually disclosed to me that she also was a leukemia survivor, and she showed me her scar, which I also have now on my collarbone, around my collarbone, where they insert your port for chemo. And she showed me her scar. And this was when I had my port in, and she kind of pulled her shirt back and said, I also too had leukemia, and showed me that and said, she said there is a way, is a way out of this, and she said we're going to help you with that, and she said you can have a great life again. And to see her healthy and to see her willingness to share that with me and to be vulnerable with me, I was so touched by that. And even 4 years later now, I remember that. I remember her name, what she looks like. I'll probably always remember that interaction with her. So, done skillfully, there are times where a provider finds it, as we are talking about here, the timing is right, the intensity is such that they're able to deliver this appropriately, and the content of their disclosure is appropriate as well. Um, my nurse did not tell me about her entire journey or about, how long she was sick or what her specifics were. All she said was, I too am a blood cancer survivor. I also had the kind of cancer you had, kind of blood cancer you had. So um, we saw that in video two. We saw the provider made that brief disclosure and then returned it back to the patient, which is always a good strategy if you have made a disclosure of personal information about yourself is, in what way can you finish that lap, as I say, finish the lap of self-disclosure, and then you're starting the next lap is client focused. So I think we saw improvement in video 2 here. Definitely better than video 1. So there are definitely benefits and guidelines for self-disclosure. So let's get into now some of the additional ethical considerations and clinical considerations that we need to look at. We know that the dyadic effect is really important, this openness, mutuality, like we looked at that particular model earlier that had the therapist, client, therapist awareness and wellness, mutuality, attachment, intersubjectivity, all of those elements, that it seems natural that if the client is being open, that we can also share appropriate sprinklings perhaps of ourself, right? To encourage the client to remain open and themselves be vulnerable. We also know that the benefits of self-disclosure is that it can contribute to a corrective emotional experience, improving emotional attunement in clients, in yourself, but especially in clients, using mirroring and responding. It can provide behavioral and social feedback to help a client see themselves more clearly. And it can also model effective interpersonal skills, affect management skills. What about guidelines of self-disclosure? Guidelines of self-disclosure. The self-disclosure must be for the therapeutic benefit of the client, not for the personal need of the clinician. And our code of ethics really reflect that point. The disclosure of emotion must contain real emotion. If you're going to disclose that you are feeling sad, you should actually feel sad. So you should not make a disclosure of emotion if you're not authentically feeling that emotion, because that would be considered an inauthentic way to try to connect with a client and build that therapeutic relationship. And really important, as Carl Rogers said, for us to be genuine. So we need to be genuine. If we're not feeling it, we should not disclose that we're feeling it. The clinician must feel comfortable in making this disclosure. If any part of you does not feel comfortable, you should likely not make that disclosure. So if a part of you is saying, oh, I don't know, or I'm having hesitations, or this isn't really something I want to share, then you should not share it, even if you're being asked by the client. You can always say, I really appreciate your curiosity, but that's not something that I'm really able to discuss with you. How about we talk again about what your plans are for the weekend that are going to keep you busy and keep you living your sober lifestyle, right? So again, pivoting back to the client, always a great technique. The choice to apply self-disclosure should be under the control of the clinician at the time when it is being considered and delivered. That means that you should not feel pressured by the client, by somebody else that is there, a colleague that says, oh, just tell your client what your hobby is, or tell your client, where you're from, or whatever else. You make that choice, nobody else. The technique of self-disclosure must align with the larger style of the clinician and must align with their authentic way of relating. If you have a particular personality style and way of relating, and you're going to self-disclose something, but you're going to deliver in a completely different way, that's probably going to throw the client off and be really incongruent for them. Finally, self-disclosure should be only used if the client wants it, if the therapeutic relationship is solid and strong, and if both the clinician and client are able to engage usefully about what is occurring in the treatment at the time of the disclosure. So there's some important caveats here. One of the ways we can determine if a client wants self-disclosure is to ask them. There's something that I think may be helpful about my experience that I can share with you if you think that that would be helpful with what you're going through. Would you like to hear it? And the client can either say yes or no. Some clients will actually say no and say, no, that's okay. I don't need to hear it. That's great. The fact that they're able to voice their opinion and exercise that choice, that's wonderful. But and sometimes they'll say, yeah, I'd love to hear if you could give me some insight or share something. You've been through this before, right? There are some inherent risks of self-disclosure. One of them is lack of attentiveness. So, if a clinician is not attentive to the content, the intensity, the timing, the delivery, if they're not attentive to all of those factors, and they're just, as we saw in the first video, going and going and going, and the first provider, it was the same provider, but in video one, she was not attentive to herself. Definitely. Video two, you saw more mindful attention to herself, more methodical, choosing her words, choosing what she was going to say next. Too frequent, number two. Too frequent. It's kind of like when you are making a recipe, when you're cooking some food. And if you add too much salt, if you oversalt your dish, you will ruin it, right? But if you just put enough salt in to enhance the flavors, which is really what salt is supposed to do, that can make the dish just woo, right? Really kind of come alive. That is what we do with self-disclosure is sprinkling. We don't pour. So sprinkling is really important. Now, on the other extreme, if we are too one-dimensional with clients, if we don't present ourselves as authentic with feelings and experiences and aren't strategic about giving little sprinklings perhaps to clients, then we're kind of like a dish that has no salt. You kind of taste it and it's kind of missing something. It's just kind of And that is what the therapeutic relationship can become like if the therapist is too blank. Number three, disclosing for personal reasons. So this is, again, going back to that model of the therapist awareness and wellness. The therapist is wanting to get something off their chest. They have their own agenda. They have their own level of distress. And the client seems really nice. And so they're just going to kind of unload on them. Number four, lack of attunement. So if the therapist is not attuned to what the client is saying, it can leave the client feeling like the therapeutic relationship is unproductive. And I've actually heard from clients before that have come to see me that previous therapists had spent a lot of time in sessions talking about themselves. And I think, oh no, right? That lack of attunement, not being attuned to what the client is saying, not picking up on the cues from the client. And then finally, number five, disclosure as a competency. This statement here is really important. Disclosure should be seen as an intervention, meaning that when you do disclose to a client, you should document that in your notes. You do not have to document what your disclosure was, and I don't recommend that you do, but you should document disclosure, self-disclosure as an intervention. So you would say something to the effect of, patient is newly diagnosed with cervical cancer and is feeling very confused and overwhelmed. Provider provided validation, normalized client's emotions. Provider felt that it would be beneficial for the patient to know that provider is a cervical cancer survivor with the goal of giving client hope and optimism in her journey with treatment, right? Two sentences. But what I've done there is I have framed self-disclosure as an intervention, and I've included what my goal was in providing that information to the client. So in your handout packet, you have a few different scenarios you can practice self-disclosure. I have some other scenarios we're going to look at here in the PowerPoint. Let's next talk about situations where self-disclosure may be appropriate. When a client asks directly for a response. Sometimes you may want to give a direct answer, sometimes you may not. This is really up to you. Simply because a client asks does not mean you are required to answer their question. But if they've asked and you feel that it's appropriate, you certainly can answer their question. When the client is repetitively stuck in an emotional scenario from the past that stimulates a strong emotion in the clinician. So let's say that you have a client that is stuck in a scenario of feeling a huge sense of failure, anxiety, failure. They're really struggling, feeling like they have to be perfect all the time. And maybe that stimulates a strong emotion in you because you also dealt with perfectionism. So maybe you could say to the client something to the effect of, as you were talking about the perfectionism expectations you have for yourself, it reminds me of a time period in my life where I was also struggling with perfectionism. And one thing that helped me was to do blank, blank, blank. I'm wondering if maybe an approach like that would be something that you'd be interested in talking about to see if maybe it could help you. Or you could also say, I can relate to what it's like to have these really high standards for yourself and to always have this sense of you feel like you're never doing good enough. I can definitely understand that and relate to that. That is enough of a disclosure without you having to give 5 paragraphs, right? When the clinical work is at an impasse that cannot be resolved simply by focusing on the client's emotional experience. I'm going to share at the end a vignette with you that specifically addresses this point. So keep this one in mind. Next one, when a client expresses the notion that their feelings, thoughts, or experiences are strange or abnormal, and the clinician knows the contrary to be true. When the client engages in all or nothing thinking, never, should, and there may be something within a realm of self-disclosure that helps bring them into the middle path. When the client has been struggling to achieve a particular goal and seems to be losing confidence. When your clinical ability is diminished or affected by illness, preoccupation with thoughts, or other internal or external factors. But only if the client's response to that information would be useful emotional clarification about the circumstances occurring. So we go back to Carl Rogers' disclosure of fact, I seem to have a terrible cold today. Sometimes if you are under the weather, if you're sniffling, if you are clearing your throat, if you look more tired than usual, you may need to let your clients know that you're a little bit under the weather, right? To give context to why you may not look as perky, as engaged as you typically do. Sometimes we call them sick, but there are other times when a lot of us continue to see clients when we're not at 100%. And sometimes that's kind of written on our face. And we'd rather tell a client, I've caught a little bug, but I still really wanted to meet with you. Rather than not say anything and then the client personalize it and says, my therapist was disinterested in me. My therapist was bored by me. I don't know if I'm going to go back to them. So sometimes we just need to share with a client that something is going on that's impacting our clinical ability. And then if the diminishment of clinical ability is too serious, or if the client would be harmed by the diminishment of ability, it may be preferable to reschedule the session. This may not be pleasant to hear, but there are times where people's GI systems act up, for example, and they're in the middle of a session and they realize that they need to go and use the bathroom right away. And they're not just going to be gone for a minute. And they realize that they have some GI disruption that is not going to be resolved within the realm of the session. There are times that a clinician may need to just stop the session and say to the client, I am so sorry. I've suddenly fallen ill. Again, you don't need to give graphic details. I've suddenly fallen ill and my abilities are so diminished that I'm not going to be able to give you the attention and the care that you need. Can I please reach out to you reschedule once I have felt better? And 98% of clients will understand that, right? The other 2% are probably going to be personality disordered or really low on empathy, not have an ability to be understanding. But the vast majority of clients are going to say, absolutely, oh my gosh, see you later, goodbye. And so your humanness may need to come out, your vulnerability may need to come out, because if you sit in session and you are uncomfortable, you're squirming, you're grimacing, that's not looking professional. And you may put yourself in a situation where you physically get sick in front of the client or something like that happens. And that's just something we want to avoid. So don't push yourself beyond if you feel like you need to interrupt a session or you need to cancel a session right before it starts. Sometimes it happens, and we need to be authentic with our clients about that at a level that is appropriate. Self-disclosure with specific populations, 12-step programs like the Joe and Craig scenario we looked at the beginning. We may see a higher level of self-disclosure in recovery programs. It's very common actually with minors. So working with children or with teens, some providers report that they feel more comfortable with disclosures with minors versus adults. Spiritual, religious based. So commonalities shared, if you go to the same church or synagogue, have the same faith as your client does, and they find that out, or you feel it's appropriate to disclose that. LGBTQ plus, as I mentioned earlier, some providers are very open about their status, and so that is something that we see can happen quite often. Veterans, military, so also another population in which we see that there may be more self-disclosure in terms of the provider's veteran or military service status. And we know that there are people that are veterans or in the military that may find more of a connection or more of a rapport with a provider that was a service member. And then specific racial and ethnic groups as well. So looking at any of those kinds of disclosures of experiences or one's own identities, and then any other groups that you can think of. Wanted to just include, for those of you that work specifically with minors, self-disclosure with minors. Oftentimes providers will get asked questions such as, how old are you? Are you married? Do you have kids or pets? Kind of like Karen Helen was talking about in the video. What'd you do over the weekend? Have you ever had blank happen to you? Have you ever been bullied? So we could get asked some really interesting questions from kiddos, from young adults. Here are some recommendations. Build rapport through common interest, such as music and movies, rather than sharing and sharing and sharing of yourself. This type of light disclosure can assist social workers with building a positive therapeutic alliance. Utilize expressive therapies, art therapy, play therapy, walk and talk therapy, recreational therapy, narrative therapy. So any of these expressive therapies, really valuable, building that trust and that relationship rather than relying on disclosing information. Use body language and facial expressions to convey more about yourself, your authenticity, and who you are and your personality. And then provide empathy as well, can be more beneficial than actually providing self-disclosures. So we talked about some of the times in which self-disclosure may be appropriate and indicated, and some guidelines. Now let's talk about possible times at which it may not be a good idea, and we need to either have a yellow light or a red light. First, we're going to start with issues within the clinician. And everything we're talking about on this slide directly relates to the therapist awareness and wellness of themselves and of the client as well. Clinician issues: feeling coerced by the client to disclose, feeling emotionally vulnerable, if you're concerned that the client may misuse the information or share it with others, if you have intense positive or negative feelings about the client. We call this the horn and the halo effect. Horn effect is clients that you really don't care for that much. And if you go into too much self-disclosure or even any with some of those clients, that could be problematic. With the clients that you really, really like, that's the halo effect. And that also can be problematic because when you really, really like a client, it can give us more permission to tell more and share more and relate to that client more as a pal rather than this is a therapist and a client relationship. When you disagree strongly with a client's point of view, there are some viewpoints that our clients express that we passionately, fundamentally disagree with. And it can take a lot of restraint to manage getting into a debate with a client or to share your viewpoint when, number one, the client may not even care what your viewpoint is. Number two, if your viewpoint is very opposite, that certainly can create an issue. Uh, Also, if the client asks you what your point of view is, you don't always have to tell. What you can say is, I appreciate you wanting to know what my viewpoint is on blank issue. I have a lot of different viewpoints. You know, I like you. I have some pretty passionate viewpoints. I'm so glad that you feel comfortable that you can share your viewpoints with me here, because that's what I think is important to focus on is how do you see the world, and how do you see this issue? And so that's an example, end quote. That's an example of what you could say to a client who is asking you, well, what do you think about um, illegal immigrants, right? And the client is saying, I think that they should just all be sent back to their country, right? They should all just immediately be deported. Maybe you have a different viewpoint, a strong different viewpoint, but what is the benefit of sharing that with the client? Instead, it's probably best for you to say, this is a very charged issue in our country right now. Everybody has opinions. I'm so glad you shared yours. And it's great that you are thinking about the welfare of citizens in the country, or however you want to kind of frame that conversation. Doesn't mean you have to agree with the client's viewpoint, but you can still be respectful and supportive that the client has that individual viewpoint just as you have yours. Finally, if you believe the disclosure will burden the client, and that is part of the assessment you have to make. What about client issues? What about issues that are within the client that we would be a yellow and likely a red light situation with self-disclosure? Clients who have problems with boundaries or reality testing and tend to idealize the clinician. You're the best thing ever. You are the best therapist. There's nobody better than you. These clients are very likely to distort the meaning of the disclosure. So you share something with them, and then their interpretation of it is, well, my therapist told me about what happened to her when she was a teenager, so that means that we're friends now. Also, clients who are seeking inappropriate closeness, and you kind of get that vibe, that intuitive vibe, that clients are poking and they're really trying to uncover things about you, and it doesn't feel very good. And so that's another reason that you'd want to hold back. Clients who tend to focus on others' needs rather than their own. So if you share something with them, even something simple, such as an emotion that you're feeling, will latch onto that and that they feel responsible for helping you with that emotion. Clients who are very self-absorbed or narcissistic and would experience the disclosure as an annoyance. Clients who make demands for personal information meant to disrupt or resist the therapy. Clients who are trying to avoid or distance themselves from their own feelings. and clients who are severely mentally ill or who present with serious substance abuse problems. Under the influence, having delusions, though these are not individuals that we want to be sharing personal information because they're not in full reality. And so the interpretation may be really skewed. And then if they tell other people and they're not telling, and they're telling people inaccurate things, that can be really problematic. Here's just some opportunity to see examples of how we could respond to these clients using self-disclosure. So let's look at number one. When a client expresses the notion that their feelings, thoughts, or experiences are strange or abnormal, and the clinician knows the contrary to be true. So the client says, I keep thinking that I shouldn't feel this way and that something must be wrong with me. What could we say in response? Not just validation, not just normalization. What could the clinician say in a response that is even a small piece of self-disclosure? How about this? Did you know that is a very common feeling? I know I felt that way when I was dealing with a similar situation to as yours. Second example, when the client engages in all or nothing thinking. If I don't take this job, I know I'll never be offered another at such a good salary. What do you think an appropriate, ethical, client-centered self-disclosure could be? How about this? I remember thinking the same thing when I passed up a lucrative job because I didn't want to move. Turned out my instincts were correct because the next job I was offered paid even more. Is it possible that could happen to you? So those are two examples. Let's look at two more. When the client believes they're the only one who's experienced something, the client says, I couldn't tell anyone what happened to me as no one would understand. What could we say here? That would provide an appropriate level of self-disclosure. You think no one else has had that experience, which is a simple reflection. I can tell you that I know many people who have, including myself. So, what we're doing here in these examples is again, we're not giving specifics, we're not going into our life details, we're just including elements that let the client know that not only have other people experienced this, but I have as well, right? And there's something about the mutuality when a client realizes their therapist has been through something. Remember what Reamer said earlier, the benefits of self-disclosure when done well can really assist that client therapeutically. What about this last example? When the client has been struggling to achieve a particular goal and seems to be losing confidence. Client says, I don't think things will ever change no matter what I do. Think about that one for a second. Perhaps the therapist could say, I thought that too when I was trying to achieve a similar goal, but things did change for me and I think they can for you too. Some examples of appropriate self-disclosure responses. Pop quiz time, pop quiz time. You are a therapist providing teletherapy, and your clients usually only see you in a Zoom screen. A few days ago, you broke your ankle and are on crutches. You are taking pain medication and are uncomfortable. You wonder if you should disclose this to your clients. Your next best course of action is to A, tell all of your clients right away they have a right to know your status. B, consider the possible pros and cons of your clients knowing this information. C, do not tell your clients now, but maybe after you have recovered from your injury. Or D, ask clients if they would like to know something personal about you. It's always good to consider, are there any of these answer options that you can rule out immediately that just don't sound good? For example, we could rule out D, right? Asking your clients if they would like to know something personal about you. That's not really appropriate. Now, obviously, the example I gave earlier when I mentioned asking a client if they would like you to share something with them, that is when you're doing that in the phrasing of being able to say to that client, you're talking about something. So there's a theme to the conversation already. And that is when you can ask the client, there's something that may be helpful that I share with you about my experience that's related to what you're going through that may be helpful. Would you like to hear about it? So you and the client are already talking about something versus here, this is kind of what we call a cold inquiry. You're just asking the client, hey, do you want to know something about me? Which is not really ethically appropriate. So that one we're going to strike out. We're also going to strike out probably C, because what would be the point of telling our clients when we've recovered from our injury? What's the benefit or the need for them to tell them after we've recovered from our injury? So we've got C and D are out. So that really leaves A and B. Tell all of your clients right away they have a right to know your status, or consider the possible pros and cons. So the key here is looking at the stem in the question. If you remember your licensure exam days, the stem of the question is the last sentence. What is the question asking you to do? And the key here is your next best step, course of action. So we need to think about, what do we need to do first and next? And when we look at it from that realm, and we've already ruled out C and D, that leads us to believe that B would be our best option. Consider the possible pros and cons of your client knowing this information. If we just go to telling all of our clients right away, we haven't even taken the time to critically think from an ethical perspective of, what are the pros and cons? Maybe there are some cons of telling my clients, maybe there's some pros. But to not spend the time doing that and just to immediately start telling clients, not a very good best practice move or sequence ethically. What about personal questions directed at the clinician? Dr. Hellam in her video addressed some of this in terms of, do you have a dog? Those simple questions. Have you seen the blank movie? And so, if clients ask you these questions, you're going to need to figure out, depending on the client, the setting you're in, the situation, lots of factors. Are you going to answer? What is your answer going to be? Uh, you may be thinking, have you been asked any of these questions? Has anybody ever asked you? Has any client ever asked you what your political affiliation is? How would you answer? What if a client asked you if you've ever lost somebody close to you? How would you answer that if you have or you have not? The other thing that clients may ask us about is current events, such as this that happened a couple of years ago when I was creating this training. It was about a week after the Oscars, the infamous Oscars, where Will Smith slapped Chris Rock. A lot of people thought it was, initially, they thought it was staged, but we found out it was not. This was a real moment where there were some words said and there was offense taken and somebody reacted. And so we saw that play out in just a matter of minutes live. But what's really interesting is that sometimes clients can ask us about what we think about current events. And we sometimes have to be really careful again about, how are we going to respond? So think for a minute, how might you respond if a client asks you a week after the Oscars, comes in and says, "Did you see where Will Smith slapped Chris Rock?" And of course, I mean, who did not see that? It was all over the news for a while. And they ask you, "What do you think? What do you think about that?" Right? How are we going to respond to that? Are we just going to start giving our full opinion? It was wrong. It was right. Um, or are we going to be very thoughtful and mindful of our response? This can be a really great opportunity to give a general answer and then turn it into a therapeutic conversation. And I'll give you an example. If a client asks me, "What do you think about Will Smith slapping Chris Rock?" My response would be, I was really shocked, which is a disclosure of feeling, right? So I'm making a disclosure. I was really shocked and I was really disappointed, also a disclosure, that two individuals got to the point where it got physical. And so it was just really disappointing to see that. What do you think about it, client? And they may also, "Oh, I think it was terrible," or "I think he should have slapped him," or "I don't think he should have slapped him. I think he should have controlled his temper." That can turn into you saying to the client, "What do you think they could have done differently? What do you think people can do when somebody is insulting somebody they love and making jokes about the person? What do you think that that person can do other than go up and hit them? What do you think Will Smith could have done instead?" And so this can be a really good opportunity therapeutically to use a current event and bring this back to therapy focused rather than you're just sitting and kind of gossiping and just, chatting like your friends about this current event, that it actually has a constructive meaning behind it. Couple of options for responding include turning the question around to the client. So you could ask the client, just kind of like I did, "What do you think about it?" So without even answering, you could just say to the client, "Yeah, wow, what do you think about it?" And see what they say. And then they may not even remember that you didn't really answer them because they may just want to give you their opinion. You could answer briefly and directly. You could say, "I thought it was really disappointing," or "I was really shocked. How did you feel?" So brief, direct, or you can ignore the question and move on. I really only suggest ignoring as a tactic if a client's been asking you the same question and you've already told them you're not going to answer it and they keep asking you, then that is where we go into ignoring. But with clients that are insistent, what do we do with clients that are insistent? They keep asking us the same question. "Mark, I appreciate your need to know more about me. This time is for you and about you. So let's focus on that." We have to use a lot of skill and creativity to think on our feet in these situations so that we don't overburden a client with too much self disclosure, or we don't cave into a client's continual demands. We stand our ground and our boundary, and we still attempt to keep them therapeutically engaged, even as we're maintaining that boundary. I'd like to show you a series of 3 additional video clips. These are going to be it's the same therapist, same client, kind of like we saw before, but you're gonna see 3 different scenarios. We'll kind of just, have a brief commentary in between each of the videos, and so I'll play the video 1, we'll have just a little bit of brief commentary, video 2, quick commentary, and then video 3. These are going to give you just some additional, very brief examples of self-disclosure. This is self-disclosure, too much focus on the self.
I don't know. I had my daughter so young. It's like she and I grew up together. Do you have kids?
I do. I have a 15-year-old daughter and I have a 21-year-old son. And I had them young too. Not as young as you, but I had my son really young. And when he grew up, it was more like we were siblings, but not so much with my daughter. She was more like my child.
Yeah, I get that.
Mm-hmm.
Okay, in that particular video clip, kind of similar to the one that we saw, the first video we saw with the provider and the patient earlier with cervical cancer, the therapist gives basic information and then just keeps going, right? And makes it about her too much sharing. Let's look at example 2, which is addressing the question under the question.
I don't know. I had my daughter so young. It's like she and I grew up together. Do you have kids?
I don't. I'm wondering what that might mean for you.
I don't know. I just.
I wonder if that means that you may be thinking if I understand your struggles and what you're going through.
Yes, I am so used to being judged for having kids so early. It was so hard. I was only 16.
Can you tell me a little bit more about what it was like being a young mother?
It was so
Okay, so in this clip, we see that the therapist does a good job. The scenario is different in that now she's playing the role of not having children, and she answers and says, "No, I do not." And then says, "I'm wondering if that's important to you." And so again, putting it back to the client, focusing back on the client, and therapeutically becoming curious about what the motivation is for the client asking this. And then you see that the client validates what the therapist is saying. Yeah, it seems like people judge me. And then this leads into, can you tell me more about that? Okay, and then we have clip 3. This is addressing the question under the question, another example.
I don't know. I had my daughter so young. It's like she and I grew up together. Do you have kids?
I do. And I'm wondering what that might mean to you.
I don't know. I guess, moms sort of get other moms.
I get that. I hear you. It sounds like you want to be understood.
Yes, I was judged so much for having my kids so young. It was really hard. I was only 16.
Okay, so there we see the therapist says, I do have kids. Doesn't give the ages as she did in the first video, but then also addressing the question under the question. I wonder what that means for you. And then the client is able to share, well, I think moms get other moms, and the therapist affirms that, right? Oh, I get that, right? That makes sense. So I think that was a really good example of how we could see appropriate self-disclosure. Yeah, I do have kids. I wonder what that would mean to you, and being able to encourage that in the conversation. There's also 3 more clips here. Another scenario, if you want to look at those on your own, feel free to do that. Here are important clinician considerations as we are beginning to look at what are some of these key ethical and clinical considerations. Do I have unresolved issues that I need to work out with a supervisor, therapist, or other person? Am I anxious with silence in therapy? So I fill the gaps with self disclosure or other interventions that do not serve the primary goals of the treatment. Am I trying to be liked, or do I have some need to have the client to identify with me? Am I anxious about the power of the therapeutic process and use self disclosure to calm myself? Am I using self disclosure to fill gaps in my knowledge and skills? Let's go to your handout packet, and I'd like to just show you the rest of your handouts, and then we have one more case vignette to close things out. Here are the parade of red flags. This is similar to the slide in the PowerPoint of contraindications of when you would not likely self-disclose, things to keep track of, to zip or not zip from the Zur Institute. He gives some good suggestions here. You also have some self-disclosure consideration questions. These are, this is kind of like a checklist you can go through as you're maybe contemplating disclosing, to kind of some checks and balances, just to make sure that you're looking at things such as countertransference. Is this self-disclosure in the best interest of the client? Am I in control of the disclosure? Things that we talked about in the training. Here are 10 tips for self-disclosure. Great handout. Here's a handout on online disclosures if you're interested in looking more specifically at your online or social media presence. And then there are some good case studies in here for you to check out. Speaking of case studies, let's go to our last case study here. And this is Linda Stone. Linda Stone is a social worker in her late 20s and is working with a 50-year-old client, Mrs. Bell, who is trying to cope with profound depression due to the sudden and untimely death of her husband. During the first two sessions, Linda sat quietly while Mrs. Bell talked about her husband, his death, and the emotional pain she was experiencing. She cried throughout these sessions. At the end of each session, Linda would indicate that time was up and she would see Mrs. Bell the next week. At the third session, Mrs. Bell became angry and stated that the therapist was too young to understand. Linda responded by asking, "Do you think no one really understands what you're going through?" The client then began to talk about how alone she felt. Later in the same session, Mrs. Bell again referred to Linda's apparent youth and not understanding what she was going through, since Linda was too young to have experienced deep loss. Linda responded by saying, "Why do you think that although I am younger than you, I've not experienced great loss? My father died when I was only 12 years old. While that's not the same thing as losing a husband, I do relate to the depth of your feelings. I know what it's like to feel intense pain and wonder if you will always feel like this." So here are some questions for you to consider based on our conversation we've had over the past few hours about self-disclosure. In this scenario, is the disclosure in the interest of the client? Sharing with the client, with Mrs. Bell, that Linda, the therapist, does have a loss, did lose her father. Is that in the interest of the client? We would probably say yes, because there is an interference in this therapeutic relationship. There's kind of a stuck point in that Mrs. Bell is really kind of fixated on the fact that she's perceiving that the counselor has not experienced loss, and it seems to be preventing her from really engaging. And so there we can see that the disclosure that I lost my father is in the interest of the client, because it likely will change Mrs. Bell's perception of the social worker. Is it germane to what the client is currently experiencing and expressing? Yes, it is, because the client is expressing that she doesn't believe that her social worker can really understand this level of loss. And then finally, are the content, timing, and intensity of the disclosure appropriate? This is that area, those three circles we looked at earlier. The content of it is appropriate, some of it, right? But the intensity, where Linda says, "Why do you think that although I am younger than you, I've not experienced great loss?" That is a defensive way to give a self-disclosure to a client. She could just have left that sentence out and started with another easier sentence, such as, "I truly understand your perception that I have not experienced deep loss. And I think it would be helpful to share with you that I did lose my father when I was 12 years old, and it had a profound impact on me. And I can relate to the depths of your feelings. I do know what it's like to feel intense pain and wonder if you're always going to feel like this. So, that type of delivery of the disclosure has less intensity, right? But the way that Linda's responding, Linda's probably frustrated, right? Rightly so, because Mrs. Bell is, there's this kind of perpetual challenge to Linda's credibility as not having been a grief survivor. And so there's a level of kind of edge in that first sentence that we need to take out. And that will make the intensity actually be really appropriate if she can kind of switch that around. In closing, here are some great resources if you're wanting to study more about self-disclosure, codes of ethics, different case studies. There's a great video by Dr. Todd Grande if you want to check that out. A good article by Frederick Reamer on boundaries of self-disclosure. So feel free to check that out. I hope that you have enjoyed this ethics training on self-disclosure. I hope that it's gotten you to think more about what your viewpoint is on self-disclosure. The last thing I would ask you to do is remember that 0 to 10 scale that I asked at the beginning. What is your level of comfort with self-disclosure? Look at the number, or actually pick a number now that your level of comfort is at in self-disclosure at the end of this training. And is it the same as what the number is that you wrote down in the beginning? Is it the same? Is it lower? Is it higher? Interesting. Just kind of look and see if your perception and comfort of self-disclosure has changed. Thank you all again so much, and have a wonderful rest of your day. Bye-bye.